what I will do for you today is really be your reality checkpoint. My job, I think, today is to give you the view from the trenches of what it's like to be in healthcare, to be on the ground in the trenches of healthcare. And that's what you're going to get from me today, pretty much the reality of what I'm doing on a day-to-day basis, because it really isn't easy. The answers I give are not going to be pretty. They're not going to be sugar-coated. I'm just going to tell you how it is, and I think it'll give you a nice window into really what we're dealing with on a daily basis. Now, I got to tell you, it was particularly difficult at first to think about being on this panel, because I'm on a panel with, the guy who's not paying me what I'm worth, and the other gentleman who's trying to buy my hospital. And I thought, oh my gosh, how am I gonna survive it? But and he's also trying to ration my health care, but we'll get to that, I'm sure. But it's not going to be an easy panel. It's not an easy discussion. But the most important thing is, despite what we're going to talk about today and our different vantage points, which I think are going to be equally unique, we have to work together. I think the three of us will get that in the end, that we must work together. We must correct this problem, because it is horrific to live it every day. Now, I, like most MDs, I, for lack of a better word, practice from my heart. So I just want to come in every day, and I want to take care of my patients, and I want to be allowed to do that in the way that I think is appropriate and fitting. That's a problem. I treat patients from my mind and my heart. I don't treat them from a balance sheet. It's a problem. I can't do that anymore responsibly. I can't. I have got to have some sense of business and a sense of fiscal responsibility. This is new for doctors. When I talk today about the opinions of myself, they're really the opinions of all of my colleagues. Many of them don't have the fortune of the skill set that I've been provided by Anderson. And so those doctors particularly are just struggling under this, healthcare reform at this point. But a physician who's not practicing with a good business sense is a physician who potentially is going to have problems down the line in terms of developing and being able to keep their practice alive, whether that's an employed physician by a hospital or an independent physician.
I think that a lot of folks look toward the Kaiser model as one that has been effective over the years, and certainly at UCLA, as hospitals begin to dry up and disappear from the scene, I think we're going to see that there's just a few of the larger players left in Southern California to do that. So we actually are starting to look at which practices do we need to collaborate with, which facilities do we need to collaborate with, so that we can begin to sort of define our own accountable care organization. And I think that realigning the incentives for the clinicians certainly is part of the equation. And I think that I'd much rather be involved in something that says, maybe I could get a piece of the action if I can help reduce the cost and improve the quality of a patient population. Mm-hmm. That'd be really interesting to us. And I think we do have to get off of just crank out another MRI, another CT, another, because that's where the incentive is placed right now. So we're doing that. And I also think that from our perspective, the better job that we can do keeping you out of the hospital, keeping you out of the clinic, and keeping you in the home, both pre and post, I think it goes to the wellness issue that we need to be focusing on. Mm-hmm. So I think part of that resides with us at UCLA or all the other organizations out there. And what are we serving in our cafeteria? It was just 2 years ago we had, fried buffalo wings, so or potato chips and things like that. Now all of those are off the menu. We have to be responsible ourselves before we can ask others to be part of that equation. But yes, I think the Kaiser model is a good one. I think it has to be modified slightly for an academic medical center, because we don't want to stifle any innovation, and we also have a fairly hefty teaching mission. But yes, I think it's a good one.
Yeah, I loved your question. I sort of agree with you as well. I think the Kaiser model really epitomizes what we each sort of said at the podium, and that is the collaboration, administration, collaborating with physicians, collaborating with payers, and it epitomizes that. I think it's a tremendous system. I can tell you from the doctor's standpoint, there's a lot of doctors wanting to work at Kaiser, wanting to be there for several reasons. I think one of the main reasons is something that you spoke about. in the Kaiser model, the doctors are employed by the hospital. There's something that happens to doctors when that occurs. They suddenly lose the inclination to compete with each other. I think what the consumers don't understand is when you come to the hospital, you think it's this wonderful altruistic, bed of great healthcare, and it should be. It is. It is when it comes to taking care of patients. But the ugly truth is that doctors compete amongst each other when we're not being paid by an institution. And at Kaiser, where each doctor is paid and paid fairly, fair market value, there's less inclination to compete, and there's actually a stimulus to collaborate, which is really key. It's key for clinicians to collaborate in a multidisciplinary approach to take care of you. That's how you're going to get the best medical care. So I agree also with Shannon. It's a very solid model, again, from the physician vantage point. But there are those physicians that really want to just have that independent practice. But I'll tell you, that is really dwindling. I don't know what your experience has been, but I see the private practices and the small group practices really going by the wayside and opting out at this point. And it's just based on a financial need.
Jay?
Well, I think Kaiser is a positive model, and we have a lot of other models like it around that are smaller. But I think there's an issue with Kaiser. I don't think it's that economic. And I'll tell you why. The big cost increases that have occurred, particularly in California, are the result of government underpayments shifting costs to commercial payers. Yeah. Kaiser doesn't have that because they don't take Medicaid, they don't take uninsured. If you actually factored that in, we've probably had there's probably 25% of your non-Kaiser premium is really a phantom tax to subsidize undercoverage in the system. I think if that were balanced out, there'll be multiple models that'll work. And I think that's the best thing. Because I think if we go to one kind of model, if we corporatize the entire system, it won't work. Kaiser has to compete against other models, but it has to be a balanced playing field.
Failure to treat. Failure to treat is one of the most common lawsuits that physicians face. If I go to a patient's bedside and I fail to treat them or withhold treatment, I get sued. Bottom line. If I come to your mom or dad's bedside, 92 years old, in a coma, on a ventilator, on dialysis, with tubes going in and out of them, and now they want a triple bypass, if the family tells me to do it, I can advise them about the risks of the procedure and the likelihood of a good recovery. But in the end, if they say, this is the phrase we get all the time, I want you to do everything. Done. I can't say no. I don't have that ability to do that, nor ethically can I do that. My job is to do the best care that I can for that patient at the bequest of their family. The other side of that is withdrawing treatment. I cannot tell you the number of times I've been at a family's bedside where there's absolutely no hope of recovery. We're spending, as you said, thousands and thousands of dollars at end of life. I think the statistics stand that the most dollars are spent in the last year of life or somewhere in
well,
that,
actually, the most dollars are actually spent in the last 10 weeks of life.
10 weeks of life.
52% of healthcare costs are in the last 10 weeks of life.
There you go, 52%. And it's because I want you to do everything for my mom and dad. And so driving those costs, they can't even factor into our mentality when we're practicing defensive medicine and trying to do, which is another discussion we really should have today, and try to do the best that we can for each of the patients that we're obligated to do. And so it's a big problem, but that withdrawal of care is another tough problem where family members simply cannot make that decision. It's a tough decision. I know it. I've been there. We've been there. It's a decision that's filled with so much guilt and so much difficulty that we will keep anybody alive at any cost because family members simply can't get to that decision point. And that's where I think, Stan, you're saying that that's where the most dollars are put in.
But I also think that we don't do a good enough job when it comes to communicating with the parents, the family members, in terms of what the options are, what really is the likely outcome. Right. And I think, there's palliative care programs. Most people think about cancer, but it's not just about cancer. It really is about, we need to create programs that support end of life and make, I think, the kind and compassionate education to those family members.